And Anton, before Ashley, before y'all, I can give you back the screen to be the sharing screen. We're trying to get it turned on to YouTube, so I'm not a host yet. But so maybe you just talk and introduce a person, and I'll share the screen with you in just a second.
Okay. So I see the screen shared now.
Good.
So somebody's on mute. I see your lips moving, but I don't hear any words coming out.
All right, there we are. Good morning,
there you go.
everyone. Hey, I'm Dr. Ashley Hink. I'm one of the trauma critical care surgeons at the Medical University. I'm also a violence and injury prevention researcher and work at the national level with the American College of Surgeons on firearm injury prevention. I'll let Dr. Andrews introduce herself and then we'll get going.
Yeah, good morning. I'm Dr. Annie Andrews. I'm a pediatrician at MUSC. I'm also the director of advocacy and work in gun violence prevention. So thank you so much for having us this morning.
All right, so I'm just going to jump right in and talk to you a little bit about a proposed program that we've been working on for a number of months to get off the ground at both the Medical University and with our community to help address youth and community violence. And so really quickly, I think, a lot of us know this, but our community and our state, it has a problem with violence. And so based on the most recently available 2018 CDC data, between the ages of 0 and 24, we have the 4th highest homicide rate in the country. We're tied for 4th. 6th highest overall amongst all the age groups. And unfortunately, our numbers went up in that last year of the vital statistics that are available compared to a lot of other areas of the country that actually went down in that time period. It's important to know that about 75% of these homicides are committed with firearms. And I think, unfortunately, this year, we're probably going to see globally increases again in assaults and homicides, both in South Carolina and across the country. And of course, we know that this is in our own community. This is a geospatial map that I created using some of the cases that are reported in the media that are picked up in terms of firearm assaults and homicides. And we know that this frequently clusters in communities and really in neighborhoods down to the street level. And certainly we have police data that helps us understand this as well. But what we know is that there are communities that are higher risk in addition to individuals that are high risk. Based on the data just from this year alone, we know that our homicides are up, and this is based on police OpStat data. Our homicides are up 80% within the Charleston Police Department precinct. And I did an analysis of our data between May and July of this year, and our gunshot injuries are up 70%. We hear a lot about what's happening in other parts of the country and in other urban areas, but this is happening in our community right now. And this is profoundly costly. Last year, there was a really fantastic report published by a congressional committee doing an analysis financially of the cost just of firearm violence, not even of all types of mechanisms, and found that the cost in South Carolina is over $4 billion, almost $1,000 per person. And studies estimate that the cost of a single homicide to a community is just short of $500,000. And that doesn't really count a lot of the other costs. We know that's just the tip of the iceberg, right? And so when we think about the immediate effects, we know what they are: death, injury, the psychological trauma of an individual that experiences it. But what does it do to them after? What does it do to their families? What does it do to their communities? Those are actually harder to understand and harder to quantify, right? And so we know that there's ongoing disability, PTSD, there's changes in income and family structure and family needs, educational and employment opportunities. And a lot of this ends up being in a very vicious cycle, right? Because unemployment, poverty, generational trauma, disparities, these all increase the risk of experiencing violence. And then individuals who do experience violence and witness it or live in communities with it are more likely to have these outcomes as well. And so it really becomes a very vicious cycle that can also become multi-generational. And I think, as we know, compared to a lot of other public health problems, we're a little bit behind the ball on really treating violence as a public health problem, like we would a contagious disease or chronic health disease. And a few years ago, we started to see a few hospitals really step up to the plate and say, you know, we're really tired of seeing especially our young men in our communities victimized by violence, and sometimes coming back 2-3 times with injuries, or not getting the services that they need and having opportunities prevention and intervention like we do for every other disease. This is a really fantastic article in the Huffington Post that was written that I think really brings a human touch to what these do. And I'm going to walk you through what these are. And so a hospital-based integrated community violence intervention and prevention program, it's really for patients and their families, and these are children and young adults primarily, to help prevent and reduce violent injury, really break cycles of recidivism and perpetration of violence, and also to improve their outcomes socially, economically, and also their health after violent injury. So what does it look like? Really, it's capturing individuals at a high risk moment. And so at the time that they might experience a violent injury or present to a scenario where they have risk factors for injury, whether it's in the criminal justice system, the healthcare system, in schools, when we're seeing red flags for potential violence, that's an opportunity for us to intervene. In the healthcare setting, when we identify these individuals, the term wraparound is what we use. So a case manager or a client advocate, typically someone with a master's in public health, social work, education, psychology, or even community health workers, sit down with that individual and really try to understand what is it that's put them at risk of violence and how can we help them never come back again with a violent injury. We identify their risks, their traumas, their needs, what resources they have, and create a very detailed, individualized action plan for that individual, identifying what resources we have in the hospital setting and the community setting, and provide very intensive follow-up, months and sometimes years, and integrate in with their family and their community support systems to help address the underlying roots of violence. And what these services look like are things like education, GED opportunities if they did not finish high school, tutoring, coordination with their school counselors, providing employment opportunities, employment counseling. Sometimes they need tattoo removal if they've been in a gang, right? And they have got a tattoo on their face and that's a barrier to getting a job. Providing job training, conflict resolution work, providing outlets for creative and maybe recreational outlets, mentorship, whether it's through a faith-based group or mentorship nonprofits, providing them with healthcare, hooking them up with primary care services, mental health services, finding ways to access health insurance. 50% of my patients who present to MUSC that are victims of violence do not have health insurance. That's very high, and that's very high compared to a lot of other states. And so it's very hard to get individuals the care that they need. And there's data that shows that they do not have good aftercare when they do not have health insurance. And so if we have opportunities to connect them to services, that's a great way to help get them on a path to recovery and getting them the services they need. And we coordinate with criminal justice systems. It might be if they have a condition of parole, that enrollment in this program can be a condition of that parole. We also coordinate with the solicitor's office and help them get victims of crime assistance. So these are some of the things that are put in place by hospital and community violence intervention programs that truly address the underlying risks of violence and get them on a path of recovery and better outcomes. There's also opportunities to team up with violence intervention within the communities themselves. Some of you might have heard of Cure Violence and what it is, and also Advanced Peace. And these are violence deterrent strategies. And so just like I showed you that geospatial mapping earlier, we know that neighborhoods specifically are higher risk. And if you start to see multiple shootings in a short time period and potentially retaliation violence, these are boots on the ground, right? And so sometimes volunteers, community health workers that really engage people in the community at the street level to help break cycles of violence and help identify individuals that might not interact with us, right, in the healthcare system yet or in the school system that are at risk and might be able to plug them into services at that level. And just to show you, and this is just one example, there's a lot of great data behind these programs. This is one of the founding ones in San Francisco that provided a wraparound hospital-based violence intervention program. They enrolled individuals that were determined to be high risk of violence or experiencing violence. And these were sometimes children between the ages of 10 and 30. The budget's around $300,000 a year. They enrolled over 250 individuals over a 3-year period. And what they found is, compared to people who were not previously enrolled, that they decreased violent reentry from 16% to 4%, a really dramatic drop. And when you think about how much a violent injury costs, especially a repeat injury, which tends to be much more potentially lethal and morbid, and what that does to an individual at all levels, it's pretty profound to see that much of a decrease. The services most associated with success are mental health support and getting individuals employment. And what they found is, just in healthcare alone, that every $1 spent was $4 saved. And that does not include the other social benefits, criminal justice savings, and all the other things that we could potentially think about. And so, like I mentioned, though, this has to be a community partnership, right? It can't just be services within the hospital. The programs that have the best success are integrated into the community. And this means partnerships with local government entities, education and employment entities, and nonprofit and anti-violence groups. And so this is our proposed model. It's built after other hospital-based violence intervention programs, where we capitalize on that teachable moment and identify what individuals' needs are to help break the cycle of violence and support their recovery, utilizing education, employment, criminal justice resources to help get them on a better path. So let me just break down what this might look like for a client. And this is actually someone that I took care of, and I would say did not have the resources in place to adequately take care of this person, because we currently don't have a formalized hospital-based violence intervention program. But we pieced together what opportunities we did have. But I want you to think about what we might be able to do for all of these people that we interact with. So I took care of once a 16-year-old who came in with a laceration to the arm after he punched through a window. Obviously, punching through a window is not a typical reaction that we would expect as a way to handle conflict, right? And I went in to talk to him, and he was very tearful, very poor eye contact, did not want to talk to me. And when I asked him why he punched the window, he told me that he had been locked in a room for punishment. So clearly there's some red flags going off, right? And so we might identify an opportunity to refer this individual for needs assessment and integration into a hospital-based violence intervention program. Because what we learned about him was this: his parents were recently separated. He had experienced very physical, extreme punishment in the home. He had started to get in fights at school, endorsed recent marijuana use. His grades were plummeting. We learned that there was a firearm in his home, and he had symptoms of PTSD. These are red flags for experiencing violence and potentially perpetrating violence. And also, he's on a path educationally and economically, right, that might cause a whole host of other negative outcomes. What might our plan look like? Well, we have trauma psychologists that work specifically with both children and adults that we could potentially hook him up with, that specialize in treatment of violence victims. Obviously, a CPS referral for concern of child abuse. We might engage with him to coordinate with his school counselor to help put him on a plan to address his grades and performance in school. We might find him a peer mentor in the community, hook him up with a Parks and Rec program, and maybe find him a scholarship for an outlet for something that might interest him, or a summer internship, right? Lethal means counseling. Tell his family, hey, there's a firearm in the home and he's high risk. Let's talk about a way to secure that firearm, or take it out of the home temporarily until we can get him help, okay? And what that follow-up might look like is weekly touch-ins. Our client advocate would see him in his community, have contact via phone, email, virtual visits, follow up with all of the programs that we get him hooked up with, and ongoing mental health support in coordination with his family. And this sometimes is months and months of work to help someone like this. I will say it took a lot of work given our minimal resources, and we were able to do a few of these things for this individual to help get him on a better path. Most of my patients, I can tell you, leave our doors without a good plan in place to prevent them from ever coming back to us and to help them on their recovery like we should. I think one of the most telling things about these programs is our patients and patients that are integrated into them find so much value in them and the studies of hospital-based violence intervention programs. And I think this quote captures it. A lot of the guys tell us that this is the first time someone actually cared about what happened. A lot of our patients hit our doors, right? And sometimes with a gunshot wound. And And sometimes people are judgmental, right? And forget to be trauma informed. And what they need is to be cared for and loved and given opportunities for prevention and intervention, right? And so this is a great example of that. That's low cost and very high yield that can help in recovery. So what this looks like is these programs typically function on a budget of around $300,000 a year. Most are funded typically initially by a hodgepodge of funding opportunities. Sometimes city budgets will help cover them, grants, institutional foundations. And I'll say that in a lot of places like the one in San Francisco, the city found it to be so beneficial that it's just a line item in their budget because it helps address crime, public health, and healthcare needs. And in other states that are a little bit more progressive have actually started funding these altogether, such as New Jersey. Staffing typically includes a director in addition to the client advocates. And sometimes these people have background in public health, social work, education, psychology. And sometimes we utilize individuals who might, have health, don't have advanced degrees, but have high school degrees and might be really interested in this work, or might have been previously involved in violence and want to provide, put their life's work towards helping prevent it and get trained as community health workers to do this. And we would utilize interns and trainees and obviously have connections with the city. Typically these programs function so that they have a monthly check-in meeting with people from criminal justice, perhaps a mayor or someone from a mayor's office, in addition to all these stakeholders to really hold each other accountable and help specifically talk about high-risk individuals. And again, we have an opportunity. When you look at where hospital-based violence intervention programs are, interestingly, a lot of them are in states that have made headway in their violence. We are one of the states that are not, right? And so a lot of the states that have some of the highest homicide rates in the country do not have a lot of these interventions. And I think to no surprise, a lot of them are in the Southeast. We have a really fantastic opportunity to capitalize on our resources here to address this public health problem. And there's really fantastic examples in other communities that I think provide a lot of framework for this. And so I'll say that we've secured some money from DHEC, a one-time amount of $150,000. We've been applying for grants and have a few grants in line right now that we're waiting to hear back from. And there's interest amongst the institution to partner, whether it's through a partnership with another grant, partnership with the city, to help provide some sustainable funding for this. I think as a way to provide a very needed public health service that we're currently not doing in our community. And I think it's important to remember that the Department of Public Health has almost zero resources dedicated towards violence prevention in the state of South Carolina. And so this is a meaningful way that's multidisciplinary and addresses the roots of violence, right? And improves outcomes for individuals and doesn't rely entirely on policy, which can take a long time, especially related to violence and firearm prevention. And so if we want to do something that's evidence-based, this is a great opportunity to do that. And so with that said, thank you for your attention, and I would be happy to entertain any questions.
Great. Thank you very much for that presentation, Dr. Hink. I know I got like 15 billion questions, but I'm not going to ask them, and I'm going to open it up for members of the Health and Wellness Advisory Committee that may have questions about this. And I see a hand raised from Carolyn Murray. So Carolyn, please go ahead.
Good morning, everyone. Glad to see everyone on the call this morning. Dr. Hink, thank you for an outstanding presentation. I have a couple of questions for you too, but I will be limited. As this group knows, I always have tons of questions. But I heard you describe what sounded like a situation that became very personal for you. And I'm wondering if you take a lot of this, the weight of what you're doing and trying to do home with you at night. It sounds like teachers being forced to dig into their pockets to support their classrooms. And it sounds like that's some of what you've had to do.
Oh, absolutely. And, I think what's frustrating for us, I think, in all of our professions, right, and especially as healthcare providers, because we want to try to fix everything, right? And there's a lot that we can't. And what we know is that when it comes to health outcomes, most of it actually isn't in our control, right? A lot of it is related to social determinants of health, economics, policy, access to care. And I think there's going to be a shift in the future, right? Where that's really where we go. Public health investment matters if we want to make outcomes. And it does become very frustrating when we don't have the tools and the resources to help address those things. And yes, I think that is personal. And plus, this is work that takes a lot of time, right? And we've been meeting people, talking to anyone we can, right? And lots of late nights, writing grants and trying to put together resources to help my patients that currently do not have services in place, and to also convince people to care.
Go ahead, Carolyn, and see your hand again.
This is my last question of the morning. Dr. Hink, I imagine that you probably recognize that people who are incarcerated could also use some of these services and some of these interventions. Is there a possibility? Is that something that you've been looking at as well?
Yeah, so that's a great question, because I think that's been a struggle for a lot of programs, because there's a lot of barriers, right, to integrating into jails and prisons. However, what I will say is that there have been some programs that have worked with individuals who might be released, right, and are integrating back into the community, and definitely individuals who might be on parole. For instance, in Baltimore, that was something that they did, was they targeted people who were on parole and made it a condition of their parole to participate. And they had significantly improved outcomes, not only in violence recidivism reduction, but a lot of those individuals were more likely to stay out of the criminal justice system. And so if it's a condition of their parole, right, they'll be obviously more likely to participate and also get services that they need.
Paul, I saw your hand.
Ashley, I heard one of your comments or one of your slides talked about looking at resources, community resources. What can we do from the city side to help you identify resources that are potentially out there for you?
Yeah, well, I think that, let's just be frank, money, right? And so everyone's budget is, we know, compromised this year. But this is an opportunity for the city to perhaps contribute some portion of funding with the medical university, right, as we work on other outlets, whether it's philanthropy, grants. But from a sustainability standpoint, the programs that are the most sustained and the most effective in other cities tend to have some degree of city support, if not all of their budget being city support. And so that's one way. But I also think, right, it's a matter of coordination, our stakeholders. So people from Parks and Recreation, criminal justice, identifying other individuals who might be able to contribute and say, hey, we have this program that might be able to help. Let me tell you about it, right? So we can get individuals referred to it. Perhaps it's, coordinating to get in front of the department, people that work in the Better Business Bureau or Commerce to talk about ways to get individuals jobs, right? That might have barriers to getting them, and how investment in this is helpful for the community. And so I think there's a variety of ways outside of just financial support, but then also coordination of stakeholders and services.
Paul, it's Lori. Dr. Hink, I'm the recreation director for the city of Charleston. I'll ask Paul to share your contact information, and maybe we can set up something so I can share with you the parks and recreation programs that we have, answer some questions about where things are in the community to help you, and also maybe work out a way that we can do financial assistance if money is a barrier to get folks into our recreation programs. We'll be happy to do that.
Absolutely. Fantastic. Nice to meet you.
Nice to meet you too.
So in the spirit of time, I'm gonna keep us moving. Dr. Hink, I'm gonna probably connect with you since we're both at MUSC.
Yes.
Because I have lots of questions, but I do know a lot about what Johns Hopkins has been doing as a part of this. One of the things that they did to also address this issue is that they banned the box on all of their applications. So to apply for a job at Johns Hopkins, you don't have to disclose that you have a criminal record or that you are a convicted felon at all. And this has been a way for them to be able to bring more people in their workforce. And I've always learned as an organizer, community organizer, that the biggest and most effective anti-poverty program in America is a good paying job. And that's what a healthcare job is.
Yep.
So I'm going to go to the next agenda item, and I see Mayor Tecklenburg has joined us. So welcome, Mayor.
Thank
I
you,
want
Mr.
to
Chairman.
go to the Fast Track Cities shape update with Aaron O'Brien and give us an update. And then we're going to let Mayor say a few words after this presentation.
Morning, folks. Thanks for having me again this morning. Paul, do you want to drive with the slides or? Okay.
Paul, you're on mute. We can't hear you.
You should be able to do them on your end.
All right. Give me the power. I'll share my screen. How's that? All right. Hopefully y'all can see that. So again, thank you for having us back to give a quick update on our Fast Track Cities activities. We've been invited to do this every couple of months or so to give you an update on what we're doing as we make progress. Also on the call today is someone you're all very familiar with, Dr. Katie Richardson, our local public health superstar, and Dr. Eric Meisner, who's also at MUSC, infectious disease rock star in his own right. So the three of us kind of make up the core of this Fast Track Cities work group here in Charleston. So just a little background. This seems like an absolute lifetime ago now. This was June of last year. And little did we know then how much would change in the upcoming year. But this is Mayor Tecklenburg signing the Paris Declaration, which officially made us the United States' 24th Fast Track City. And Fast Track Cities is really a collaborative effort to use data to inform strategies to improve the diagnosis and treatment of people living with HIV and to prevent transmission of HIV. So it's really a wonderful thing that we all came together to rally around this, to help move some of our numbers on HIV. And as this is kind of truly based in data, I'll start with this. This was our first Fast Track Cities activity, was to figure out what exactly is kind of the state of HIV in our local area. So for the purposes of Fast Track Cities, when we say City of Charleston, we're really talking about the Tri-County area. So you can see in an ideal world, this is called an HIV cascade. You can see why. And in an ideal world, all of these bars would be the same height, right? So the first one is the amount of people that we estimate are living with HIV in our region. The second bar there is how many of those people we've actually tested and diagnosed. The third bar is all of those people who are in medical care and getting medications. And the last bar is kind of the goal of HIV treatment, which is viral suppression, which means that patient is much more likely to stay healthy and much less likely to transmit that virus onto other people. And as you can see, the biggest drop-off for us in our region is between diagnosis and receiving care. So that means people are known to be living with HIV, but for one reason or another, they're not accessing the medical care that's available to them. And of course, this is not unique to Charleston or in fact, South Carolina. This is DHEC's latest out of care map. So in our Charleston region, we can see there are probably about 1,000 patients who are living with HIV but are not receiving medical care. And that's kind of our focus with this project, is trying to reach those folks and get them back into medical care. The good news is there's already some really great efforts going on in Charleston around this. All of the major players, Palmetto Community Care, MUSC, DHEC, and my clinic, the Ryan White Wellness Center at Roper St. Francis Healthcare, are all engaging in outreach efforts to bring people back into care. And I've actually interviewed all of the staff around the city as part of the Fast Track Cities initiative. And there are some great best practices going on. We have really great skilled staff. But there are some barriers that we face too. So we're not allowed to share a lot of data just because of patient privacy. And so it just kind of hamper our efforts somewhat because we could work better collaboratively. Also, the patients that we're trying to reach often are transient or unstably housed. They've got a lot going on. So they're often difficult patients to reach. But But as part of the Fast Track Cities implementation and planning, we hosted this meeting just last week on Thursday, and Paul Wieters was with us for that meeting, which was really great. And this was really a strategic planning meeting. This was hosted by IAPAC, who's the international organization that heads up Fast Track Cities. It was very well attended by a number of stakeholders. And this was one of 4 national meetings that they've held so far across cities across the United States. And what really kind of rose to the top for us during this meeting as we were planning was a lack of representation from the people we're serving, right? So people living with HIV, with specific emphasis on young people of color who are disproportionately impacted by HIV, but are underrepresented on planning bodies and agencies actually serving the community. So what we proposed as a Fast Track City committee and what we'd like to bring to the city for input is we've proposed a citywide advisory group comprised of people living with HIV. Now, there is some precedence for this in the Rhine-wide HIV world, but it's almost always on an agency or an individual clinic level. So this is quite unique to create this for an entire city jurisdiction. And so we're really looking for a partnership in this between SHAPE, which is our HIV public health group, and the city of Charleston. And particularly because HIV doesn't exist in a bubble, we really want this to kind of, or we feel it'll fit really well in the Office of Diversity, Racial Reconciliation and Tolerance, because there are so many social determinants of health that impact HIV, including discrimination, racism, poverty. And so we've actually already spoken to Amber Johnson. She has a real interest in this. And we've spoken to a very dynamic young woman who is actually a DHEC employee and serves on SHAPE. And they're both interested in a partnership between the city of Charleston and SHAPE to make this group happen. One of the things we'd really like this to become is kind of a leadership incubator. So we would like to compensate the members for their contribution. We're asking a lot for them. And we really want to use this as an opportunity to build skills and kind of workforce development for these folks who are underrepresented in the work we do. So the goal of this group will really be identifying better ways to reach and engage people living with HIV who have fallen out of care, and to give us that firsthand experience of what it means to be living with HIV and really inform what we're doing as medical providers, with a lens of kind of real community involvement. So that's kind of our request from the city, is to carve out a little bit of Amber's time to help us coordinate this. We've got a great team of people that will help support this effort too. And of course, I'll end with this slide. So as part of doing this, we really want to have a press release to kind of showcase the city of Charleston's involvement, the involvement of you, Mayor Tecklenburg, for assigning us on to this Fast Track Cities effort, and to showcase this dashboard, which is on the Fast Track Cities website. There's a whole host of information on the Charleston page, including now COVID-19 numbers, resources, as you can see, for people who are trying to identify testing and treatment services in our region. So I'll leave it at that. I'll let Katie Richardson and Eric Meisner answer any questions that we might have. But thank you again for your time. We really appreciate the invitation, Paul.
Yeah, thank you very much, Aaron, for that update. A lot of great work. Of course, some challenges to overcome, but the fact that we are one of 24 cities in the country who are as a part of this effort, I think is pretty impressive and important, and something that I don't think most citizens in the city know about, or even in the state know about. And you know, I always look for an opportunity to toot our own horn, because sometimes if you don't toot it, nobody else is going to toot it for you. That's my philosophy, at least. Anybody have any questions? And of course, I'm going to open it up to Mayor for making any remarks that he would like at this point as well.
Thank you, Mr. Chairman. But Aaron, was Katie or Eric going to add to your presentation? Maybe not.
Thank you, Mayor. we did work on it together. And so I think, you know, we wanted to present the idea to this group. We wanted to see if there were questions, if there is interest in supporting a community-wide sort of, you know, advisory group of people living with HIV. And if you personally would be in support of Amber helping us out with this, and you know, we'd be happy to talk more about this idea, you know, with a group that is particularly interested, or we can bring it back next month as well. But really sort of felt like this may be the right next step in moving towards ending the HIV epidemic in the Charleston area.
Great. Well, I think it's a grand idea, and I want to thank you and Aaron and Eric for all of your efforts in keeping our Fast Track Cities initiative going and really getting it up off the ground. I got to admit, Amber is going to be a little busy over the next few months. We just had our first meeting last night of our commission on diversity and racial conciliation. So honestly, I might ask Paul or somebody else on staff to help you over the next few months, because she really is going to be covered up with that chore. I saw the presentation just recently, and it looks like they've gotten off the line already, but I wanted to thank Drs. Hink and Andrews for bringing the presentation on to this committee, because I thought that a lot of the things that are encompassed in their program, their project, are impactful and are all things, goals of the city to reduce domestic violence and provide some educational opportunities and try to catch some kids before it's too late. So those are all good things. And you know, right now is a difficult time for the city in terms of committing extra dollars, those kinds of resources, but there are other ways that we can support. And so I'd like to garner the support of this committee and recommendation to council to support that program in any way we can as well. So getting back to Amber and the Commission on Racial Conciliation, they'll be looking at really all aspects of our community life and where racial inequities exist and how to address them in the future. And of course, one of those areas is in healthcare and health delivery. And there's been a lot of great work done on this issue locally. Dr. Bell leading the charge, but many others involved. So we have some track record, but you know, it's so clear that there are health disparities, so many health conditions where if you look at statistics, African Americans particularly are more prone for whatever reasons to those diseases. And then it manifests itself when an epidemic comes along like COVID-19, and you see the imbalance in statistics of those who have died from COVID-19. And it's because of those underlying health inequities that existed in the first place. So I'd like to challenge the committee when y'all meet either in October or November at the latest to spend a full session on bringing us up to date on where our community stands with regard to racial inequities in our healthcare system overall, and use that forum to inform this commission as to any recommendations that we may have for our city and our community, you know, kind of focusing in on that. Mr. Chairman, if that's okay, I'd like to, and this might be in short order. November would be okay, because I know you'll need a little time to put it together. November would be just fine, but I would like to ask y'all to engage in that and help inform this commission, you know, before the end of the year.
Mayor, you will get no argument and pushback from me, and I don't suspect most of the committee would as well. So I thank you for the challenge, and I definitely think it's worthy of us to not only inform you, but the entire city on what we can do in that space and to be thoughtful in that space. To your previous point about supporting our very first presentation that we had this morning that unfortunately you missed, and that's the community-based violence and intervention and prevention program. I think the city, and I'm gonna just kind of ask the will of the group, if you will. I think the city, this group would recommend that anything around violence prevention, we know has a disproportionate positive impact on racially diverse communities, particularly underserved communities. And I think, the committee would be very supportive of the city doing everything in its power to support those efforts, as well as the fast track city's efforts in this next step of setting up this core group. Because again, HIV and AIDS is also a disease that has a disproportionate impact on people of color. I remember about 10 years ago when I was, actually longer than that, 12 years ago when I was living in Colombia, the fastest growing HIV positive population were Black women age, under the age of 44, which was, unconscionable that was happening. So I think both of these initiatives should have the full support of the Health and Wellness Advisory Committee as a next step. And then also encouraging the city council and you as a city to do whatever you can to help operationalize both of these efforts to take them to the next level so we can have a positive impact on our entire community, but particularly those who many times are disproportionately impacted, and that is people of color, particularly Black people. So is there a motion to those ends from anybody that I could get a second for, and then we can just kind of vote on that?
I'll second.
So who
Or I'll make a motion, sorry.
Okay, Jennifer made a motion and Dan second. I see you saying. All in favor signify by the usual sign of voting, which is aye.
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 Those who oppose do likewise. It's unanimous. Great.
Thank you, Mr. Chairman, and I agree. Those are all great initiatives for us to work on, and thank you all for your service as well.
Thank you. So, Dr. Richardson, I'm going to go back to you and if you could give us a COVID update, and we'll leave the last 5 minutes of the agenda for Dr. Susan Johnson to give us an update, as Paul mentioned that she wanted to this morning. So go ahead, Dr. Richardson.
I'm going to let Tracy give the first few minutes, and then I'm going to fill in the rest of the time. Thank you.
Good morning, everyone. Hope everyone's having a great morning. I'm going to share my screen. Not that I'm going to talk for very long, but I'm a visual person, so I like to see all the charts and whatnot. So just really quickly, I know that I believe I showed this to you all the last time. So this is a live dashboard that we have, and this is really driving everything that we are doing in our decision making internally in the city. So we can see that we've got a couple of yellow items on our dashboard, which means that we don't move forward to the next phase until they are showing green for 14 to 21 days. And I think one thing that we've added since I was last with this group is if you scroll down to the bottom of the dashboard, we've got some more information at the zip code level. So you can actually see various zip codes, the growth rate by zip code. So that could be interesting. And then further down, we have a number of basic stats related to each zip code in the city. So I just wanted to show that to everybody really quickly. Let's see. So just like I said, a couple of slides here, just to give everybody a brief update on what we're seeing here recently. And Dr. Richardson, please feel free to jump in. So, our phased reopening of the city, this was developed as a flexible and data-driven approach, right? So all those metrics have to be green based on our stoplight indicator for 14 to 21 days in order for us to determine to move ahead. We are still in phase 2. We've been there since May 26th, probably no surprise to anyone on this call. Recently, like our 7-day growth rate has been on the rise. It's still less than 1%, which still keeps that in the green using our stoplight approach. But we, over the last 7 days compared to the previous 7 days, we've seen a 46% increase in the number of new cases. So trying to do that on a kind of 7-day basis instead of, because we all know the daily numbers are very volatile. So that's a big little jump that we've seen. And so, of course, we don't really anticipate moving forward anytime soon, and I'll get to kind of why that is in just a moment. What we've started to look at, and thank you, Dr. Richardson and DHEC for starting to put out number of tests at the county level. So we've started to kind of keep track of that and graph these out. So the top line is the number of tests, and this is Charleston County. The orange is then the county new cases, and then the darker blue are the city level, so at the city zip code level. So just kind of interesting to see how that's trending. Employee cases. I believe Jan's on the phone, so I definitely welcome Jan Park or Paul to jump in here. We've been very fortunate. We've had 0 hospitalizations from employee cases. We currently have 3 active cases, which is great. We were hitting some fairly high numbers for active cases, as well as people out waiting for test results kind of the end of July. So that's been a drastic improvement. We've had 120 total cases in employees, and 620 total employees actually tested since the beginning of this. I alluded to to why we, to us not thinking that we're going to be able to move to the next phase anytime soon. And this kind of highlights why. So as you might see here, so we had College of Charleston, the off-campus students starting to move back in on August 15th. 2 weeks after that was August 29th. Interestingly, we've seen a little jump in cases already. Citadel, their cadets are all back on campus. They are keeping those guys pretty close to campus though. So, but they've had their own issues, as we all know. And as we all know, Labor Day is upon us. So that's kind of a date that we're looking at, as well as CCSD, first day of classes, and College of Charleston Move-In Weekend and their first day of classes. Along with those, we've kind of taken those 2 weeks out, so you can see this end of September. It's probably a good to plan for the fact that we might see some increase in cases still yet at the end of the month. So those are things that are on our radar that we're thinking about. And we're, of course, talking to all the local colleges and universities. But I think what we are seeing happening in Columbia is alarming. And so I think that preparedness is our best course of action at the moment. So, and I'm happy to take questions, and Dr. Richardson, please feel free to insert or correct me in any places I might have gotten wrong. So thanks, everybody.
Great. Thank you very much for that update, Tracy. Dr. Richardson, I'm going to turn it over to you.
Okay, thanks. I'm going to see if I can share my screen as well. And Paul and I were part of a population health summit on this past Wednesday that was sponsored by the South Carolina Hospital Association and the South Carolina Alliance. And Josh Selner is an epidemiologist with DHEC. And I think this is, I don't want to take up too much time. I'm looking at the clock and I know that Susan needs to go on in about 4 or 3 minutes now. So this will be a slide set that Paul can share out with the minutes. But I think, you know, the sort of theme, I think, of all of the presentations today has really been health disparities. And so this is really speaks to the health disparities within the COVID epidemic. And I just think it's, you know, it's information I wanted to share. I don't think it's presented this way on the DHEC website. This is not information that's not out there otherwise. It's just not really presented in this way. So let's see if I can do this and then, so really I'm not going to go through most of the slides, but this is to say that we've tested over 14% of the population already, lots of mobile testing events. Here where we see that many young people have been tested. And then on the right, I think we begin to look at the real disparities, which is, yes, we have tested more Black residents than white in South Carolina with COVID. Our percent positivity continues to be high. And here we begin to see, this is looking at cases and how the disparities really widen when we started to see this bump that really sort of peaked, you know, a couple of weeks after 4th of July. The disparities really skyrocketed when we look at race during that time, and they continue to be much wider than we were seeing earlier in the epidemic. Here we see not only is it our African American residents, but also Hispanic Latinos are much more affected with COVID than their percent in the population at large. We see that the average age of those diagnosed with COVID is lower in our Black residents. And to me, this speaks not only to, and we'll look at the comorbidity information, but it also speaks to who our frontline workers are in our community and who is had to go to work face to face with the public day after day since the epidemic began. This looks at, on the left, we see COVID case rates overall, and then on the right, it looks, sorry, that's among white residents on the left, among Black residents on the right. And we see that this isn't particular to any one part of the state. Rates are higher among Black individuals across the state, but particularly in the Low Country and PD regions. Here we look at the pre-existing condition data, and that certainly we knew before COVID, but we see the significant morbidity that is added to COVID with pre-existing conditions. And we see that those are much higher in our African American residents. Hospitalizations too are much higher, and certainly that is in large part related to the pre-existing conditions, but we know that social determinants of health also play a role here. And again with death, so not only cases show significant disparities, hospitalizations as well, and deaths finally and tragically do here. And on the left, you see that the COVID has climbed to being a leading cause of death in South Carolina. If we looked at rates compared to other conditions in 2018, COVID would have been the 7th leading cause. But here, just in 6 months of COVID being in South Carolina, it's already the 3rd leading cause of death among our residents. again, the Latino community is also disproportionately affected. And finally, we look and see that the average age of death among Black residents is much lower than white deaths. So again, as we're talking about, I just wanted to share this to help you to see that, obviously we've talked about violence, we've talked about HIV and sexual health issues, and now this is COVID, I think very starkly showing that it is disproportionately affecting our communities of color. And I hope that as we commit to working on these other issues, what we see is really we need to be looking at health disparities across the spectrum. And that I hope what we do for one, much of what was presented with violence prevention would certainly also improve the health in other arenas as well. And so thanks for that time. And I'm sorry I didn't give you quite the 5 minutes that.
That's okay.
But thanks, Paul, for sharing those slides, and we can talk more about it next month. Thanks.
Yeah, we definitely should talk a lot more about that. And I think it fits great to the challenge that the mayor laid out before us. So what I'm going to do is I'm going to turn it over to Susan Johnson for the last 2 minutes. I know we had a couple other people we want to get to. So Jennifer, I want to make sure that we have the opportunity to understand how mental health is happening in our community. So I'm going to see if everybody could do an extra 5 minutes. I know I cannot because I got a hard stop because I got people in a waiting room now for me. So Dan, I'm going to turn it over to you to kind of, you the man in uniform today, so you can carry us the rest of the way. So Susan, then Jennifer, and then we'll have a hard stop at 10:05. Love y'all.
Thanks, Anton. Thank you for giving me a few minutes on the agenda. I'm actually wanted to just share a message from Councilman Seekings. He could not join us today. And Mike wanted me to give an update. Some of you may know, Mike was really unexpectedly diagnosed with throat cancer the beginning of June and has been battling this in the midst of COVID, which, as you can imagine, presents its own set of challenges and problems. He has successfully completed 8 weeks of radiation and chemotherapy and is now kind of just struggling through the effects of all that. So he has not been able to eat any solid food since the end of June. So he's very much looking forward to getting back to eating, and he's in a lot of pain right now, but wanted me to share this with you, and he hopes to be back next month. And here's you can see my phone. This is him right now. He had to go to Roper for infusion this morning, but he has a really great attitude, and I think if we can all just kind of share our well wishes with him, he would certainly appreciate that. And really looking forward to having him back and joining us again in the near future. So thank you.
Thank you, Susan. That actually was news to me, and obviously on behalf of this committee, and I'll reach out to Mike personally, but please do send him our well wishes. He's certainly been steadfast in his commitment to this committee and to public health. So we're certainly going to wish him our best for his individual health. So thanks for that update. So with that, let me turn it over to Jennifer so she can tell us a little bit about some of the mental health aspects of what's going on right now. Jennifer?
Yeah, good morning. Thank you. I will try to be fast, but I'm also going to send Paul after this meeting just kind of an overview of all the services we have going on at Charleston Dorchester Mental Health Center and even at Berkeley, because we do have a lot of opportunities to help people in many programs. But for today, I just wanted to remind you, and I sent Paul a flyer for this, but Department of Mental Health and DAODAS joined together in a grant called South Carolina Hopes. And it's a free call line for people who are under anxiety and stress, depression, because of COVID. So there's free help for alcohol and drug counseling or mental health counseling. It's for healthcare workers. It's for people affected by COVID. It even helps people transitioning out of jail to help with medications. And we'll send out the flyer again, but it's 1-844 SC Hopes is the phone number. So please call. They're happy to talk to you on the phone or hook people up with other resources. And when Dr. Hink got off the call, I was just going to mention we have several programs here too that can help with people that have experienced violence or are part of doing violence. But we have school-based counselors in the 3 counties here and over 120 schools. We've got jail transition teams and teams that can help people get jobs alongside their mental health treatment. We have people embedded in mental health counselors in all of the police stations and sheriff's departments in all 3 counties that are working with people with victims of crime. So I'll give y'all like kind of an overview of lots of things that we're doing, but remember, we are here for you. Our clinics are open for walk-in appointments every single day. You don't even have to have an appointment, and it doesn't have to be an emergency. So we're definitely here for you, and please reach out to us, and I'll send some more information about kind of all of our services to Paul that he can share later. But thank you for giving me a few minutes.
Thank you, Jennifer, for you and all that everybody's doing in the mental health community to keep us sane and well. As we say sometimes in the military side of things, well from the neck up. Obviously, we know the challenges that are being posed right now. So in an effort to try to wrap up relatively quickly, I want to thank everybody who presented today. I very much appreciate the data-driven element to that which was presented. In particular, Katie and Tracy, thanks so much to you and DHEC for continuing to provide good epidemiological evidence for the tremendous work that the city is doing towards prevention. And I encourage and appreciate the city in staying steadfast in its efforts to continue to limit the spread of this virus and take it, Katie, as you said, as a lesson for how we can continue to use prevention as the most effective form of treatment. So thanks to everybody on this committee. Thank you to the city. And let's continue to be a model for the state and the nation on how we in Charleston can take efforts towards prevention to improve the health and wellness of all of our residents. And unless there's anything else for the good of the order, I would ask for a motion to adjourn.
Dan, speaking of prevention, can I just put in a very quick plug for flu vaccines? Before we meet again, they will become increasingly available, and every year they're important, but this year I think they're particularly important. So please use whatever platforms you have to encourage flu vaccination for all in our communities. Thanks, Dan.
Yeah, thank you, Katie, for bringing that up. Thank you. Anything else for the good of the order before we adjourn?
Thanks, everybody.
Thank you, Mayor. Make a motion to adjourn for today.
You're here.
Second.
Okay. Thank you, everybody. We'll see you soon. Be well.
Bye.
Thank you. Bye-bye.